Good afternoon. My name is John Cullen, and I am the Acting Director of the University of Rochester Susan B. Anthony Centre. The Susan B. Anthony Centre works to bring, the Susan B. Anthony Centre works to bring awareness to and advocate for social justice and equality. We work in collaboration with the university community and partner with a wide range of local, national, and international organizations to fulfill our goal of translating research into policy. We would like to welcome you to our panel discussion, Emergency Responses to Mental Health Crises in the Community, and express our sincere thanks to our panelists and moderator for agreeing to participate. Please note this webinar is being recorded, and you may type your comments and questions in the chat box as the panel discussion progresses. As we begin, I would like to offer a land acknowledgement. We would like to acknowledge with respect the Seneca Nation, known as the Great Hill People and keepers of the Western Door of the Haudenosaunee Confederacy. We take this opportunity to thank the original caretakers on whose ancestral lands the University of Rochester now stands. So it is my pleasure to introduce a dear friend and colleague who will be moderating today's event, Dr. Telva Oliveras, who is Professor of Clinical Psychiatry and Clinical Medicine from the University of Rochester Medical Center. And with that, I will hand it over to you, Dr. Oliveras.
Thank you. Thank you, John. Thank you for that introduction. We have a very interesting and well-attended panel today. We thank the University of Rochester Susan B. Anthony Center for sponsoring this speaker series on addressing community inequities. Today's topic is emergency response to mental health crisis. It is not a crime to be mentally ill. It is not a crime to be suicidal. It's not a crime to have a substance abuse diagnosis. These are mental or behavioral health issues, and people who exhibit these symptoms need treatment and help. But an estimated 8 to 10% of calls to Rochester Police Department are for behavioral health or substance abuse related reasons. And a public health response is more appropriate and safer in these situations. A police response to emergency calls for mental health and behavioral health problems criminalizes mental illness when there are effective alternatives for communities already suffering from intergenerational trauma through racism and poverty. In response, the City of Rochester has developed the Person in Crisis team as an alternative to response to the behavioral health incidents in Monroe County. Just announced expansion of the forensic intervention team from 8 to 28 full-time positions to assist law enforcement handling people having mental or behavioral health crises. On a state level, Governor Cuomo has enacted Executive Order 203, which requires each municipality with a law enforcement department to implement comprehensive reforms. Our panel will discuss emergency response to mental health crisis, how effective the new Rochester City Person in Crisis team and the expanded Monroe County Forensic Intervention team will be, and what advances still need to be made. Without further ado, because we have a very busy schedule, I'm going to present panelist number one, Dr. Don Kamen. Dr. Kamen is Director of the Institute for Police Mental Health and Community Collaboration. Thank you, Don.
Sure. I want to thank the Susan B. Anthony Center for hosting this forum and also thank you all for your interest. It's good you're going to hear a variety of different perspectives on the issue of mental health crisis response, all of which are needed to have a productive dialogue to ensure that the responses to mental health emergencies meet the needs of our community. I began my career working in jails, where I saw the outcomes of responses to individuals experiencing mental health crises. I saw individuals who were incarcerated in the midst of psychotic episodes, some who didn't know where they were and even sometimes who they were. As my career progressed, I worked in the court system, trying to better understand how these individuals got incarcerated in the first place. My focus soon turned to working with police officers. If police had the knowledge, skills, and support to de-escalate individuals in a mental health crisis, they could divert some individuals from the criminal and juvenile justice systems and connect them to treatment services. I spent many years training law enforcement officers here in Rochester, and I continue to do that in many communities across the state. You'll probably hear more about that sort of training from Sergeant Boyle. It's important to note that the majority of interactions between individuals in a mental health crisis in law enforcement turn out just fine. However, two problems can and do occur. The first is what I've already alluded to, the overrepresentation or the disproportionate rate of incarceration of individuals with mental illness. The second are the tragic outcomes that sometimes occur when individuals get seriously hurt or even killed. We all know examples of that. There are a variety of factors that contribute to these bad outcomes, but rather than discuss those, I want to ask, how is it that even though this panel is about mental health crises, I'm talking about police? Well, as we all know, police have become the default first responders to many problems in our society, some of which have nothing to do with law enforcement. So let me just take a couple of minutes and refocus on mental health responses to mental health crises. Because if you remember nothing else from what I say, please remember this: a mental health crisis deserves a mental health response. I'm going to briefly review three main models of crisis response. The first one I want to mention is crisis hotlines. Everybody knows the number to 911, and we've all learned to call 911 for any emergency. It's time we learn that for some emergencies, another number that's equally easy to remember, 211, is the number to call for some emergencies. And spoiler alert, at some point in the next year, you'll be hearing more about 988, a national crisis hotline that will be tied into the 211 number, so both will work. But please know that 211 is now the number to call in Monroe County for most mental health related crises. Mobile crisis teams are the next model of crisis response. There are various configurations of these teams. Typically, they're comprised of mental health clinicians that respond in the community. Some teams also include family members or family advocates. Some have peers, that is, individuals with lived experience of having a mental illness. Some include EMTs or paramedics, although none of the local teams include those. Mobile crisis teams that are currently operational here in Monroe County include Strong's Mobile Crisis Team, Rochester Regional's Crisis Outreach Team, and the City of Rochester's Person in Crisis or PIC team, which I'm sure you'll hear more about from Dr. Lyman Torres. These are all non-police responses to mental health crises. Because the vast majority of mental health crises don't warrant law enforcement involvement, it's crucial to emphasize the importance of these services. And by the way, it's not just my perspective. The Federal Substance Abuse and Mental Health Services Administration, SAMHSA, the best practice guidelines from them published last year, states that, quote, mobile crisis teams should respond without law enforcement accompaniment unless special circumstances warrant inclusion. And what would those special circumstances be? Well, if there are concerns about dangerousness and or criminal behavior. Now, in those cases, we'd still want the mobile crisis team to respond, assuming there's a behavioral health component to the situation, but we'd also want the police to co-respond along with them. And this leads to the last crisis response model that I want to mention, namely the co-responder model. Any of the mobile crisis teams that I mentioned previously has the ability to co-respond with police. The city's PIC team in particular co-responds with police on a regular and frequent basis. In addition to PIC, the county's forensic intervention team, or FIT, is dispatched at the request of law enforcement and co-responds with them anywhere in Monroe County. And you might hear more about FIT from Dr. Aycock today. Many places across the nation are looking to transform their crisis response system to minimize the times that police are the first responders to individuals in emotional distress. And I've been contributing to that work in various communities across New York for the past several years. I know there's been a lot of work done in Monroe County to look at ways to divert calls from coming to 911 in the first place by increasing educational efforts in the community to call 211 instead. In addition, there's been work done to divert calls that come to 911 from the traditional dispatching of police to other services when that's possible. Over the past year, there's been increased calls for police reform. And what I'm talking about is system reform, but everything I'm talking about is consistent with and supports police reform. Because wherever you fall on the political spectrum, it's important to listen to and respect what our law enforcement community has been saying for years. Mental health crises should not be the responsibility of police. We need to continue to look at our systems and ensure that police are responding to mental health crises only when necessary and not as the default first responders. Before I end, I want to briefly address how what I talked about is especially important when it comes to the discussion of racial disparities and inequities. We all need to talk about race and acknowledge that systemic racism exists in all aspects of society. Because of the nature of policing, the symptoms of our societal racism get played out more dramatically. Research shows that people of color are more likely to experience use of force in their interactions with law enforcement. Likewise, data show that a disproportionate amount of fatal police shootings involve individuals with mental illness. An often quoted figure is that individuals with untreated mental illness are 16 times more likely to be killed by police than those without mental illness. Some of you may be familiar with the Washington Post database that has, for several years, tracked fatal police shootings. Almost 25% of fatal police shootings involve individuals with mental illness. So, individuals of color who have a mental illness have both of these risk factors and are therefore especially susceptible to poor outcomes in their interactions with police, which is another reason we need to have non-police responses to individuals in distress when possible. I'll end by repeating what I said earlier. If you remember nothing else from what I said today, please remember this. A mental health crisis requires a mental health response. Thank you.
Thank you, Don. That was very informative. I think it does set the scenario for our next speakers. It's a lot of work has been done in Monroe County currently to address these issues. I want to introduce everybody today to Jake Huto, who's a community member and has a completely different perspective that many of you have not heard before, but that is valuable and necessary to bring to the conversation. Jake.
Thanks. And thank you everyone for this opportunity to speak. I'm a member of DPAC, which is the U of R's Department of Psychiatry Advisory Council of Consumers. I'm a consumer, being a person who's had some mental health problems. And so I'm going to start with a little personal history about myself and my experiences concerning mental health. Um, I was diagnosed at 19 or 20 years old. I'm 38 now. But at 19, I was diagnosed with bipolar disorder, and I was in outpatient treatment for a while. And then in my mid to late 20s, I was hospitalized again, this time for schizophrenia, paranoid schizophrenia. And yeah, I had trouble finding workable treatment, especially because I was not happy with the involuntary treatment over objection that I received in the psychiatric institutions that I was at. So I've been hospitalized involuntary treatment over objection for many times. And before I finally found workable outpatient care at U of R, and so for 6 years now, I've been in outpatient care and been able to hold a job, pay my bills, pursue my musical interests, and be a functioning member of society. I still have symptoms, but I'm okay now. And during those 6 years, I've not been hospitalized again. So my experiences have led me to form some opinions and ideas about my experiences and what's going on in the psychiatric field and the legal justice field. And I'd like to share a few of those with you today. First, generally speaking, there is a lot, and I mean a lot, of reform work that needs to be done in the legal justice system and the field of psychiatry. We must thoroughly, as a society, thoroughly and diligently pursue non-forceful means of safe mental health crisis resolution. And by non-forceful, I'm talking about not treatment over objection and not involuntary hospitalizations, because those are, in my opinion, forceful. This was not done for me, in my experience. In other words, non-forceful means were not implemented thoroughly and diligently. And there was often a fairly quick jump to the use of involuntary treatment. I think we need to practice and train and plan for non-forceful crisis resolution, which is de-escalation. And I think one of the ways we do that is to plan as though the use of force is not an option. And then take that plan and use it as a first resort whenever possible. It's my belief that when we as a society have the skills, the resources, and the will to appropriately address mental health crises, it will be exceedingly rare, if not non-existent, that we will have to use force. I think that's possible. I think that we can address mental health issues without the use of involuntary treatment. One of the tools I think we need to use is expedited outpatient care. In other words, there were a few examples in my experience where I wasn't offered outpatient care immediately as an alternative to inpatient care, and yeah, that the results were not good. So if we're faced with a mental health crisis, can we say to someone, we can, have you see a doctor, this hour and initiate outpatient treatment. If the crisis can be safely resolved in this way, then there's no need for involuntary treatment. Another tool that's paramount to addressing these issues is conversation. When we see a mental health crisis in the community, I think really the first thing that we need to do is start a conversation with the person in crisis. It's an important part of de-escalation. Part of that conversation can be negotiation. What can we offer? Expedited outpatient care is one thing. Maybe it's a housing issue. Maybe someone's mental health is eroded because they're stressed about not having housing. Maybe it's food insecurity issue. It's not limited to these issues that I've listed, but those would be good starts. And I've been both homeless and hungry, and yeah, it affects your mental health for sure. I believe that our society needs to get a lot better at recognizing and respecting one another's humanity. I think it's lacking, and that needs to change. This is kind of an odd idea that you've probably never heard before, but it happened to me, and it was very upsetting, and I still remember it and wanted to address it. The tools for psychiatry have been used to limit my free speech. I guess I won't go into details about that, but I just wanted to throw that out there. Another thing that I think we need to recognize is that anger is related to pain. When I was sick, I was very angry, and people see that, and sometimes they think either, oh, this person is dangerous, which in my case I don't think was true, and or they're a bad person because they're angry. We don't like people. We don't like being around people who are angry. So we have an adverse reaction to that. But it would be helpful if we could recognize that when we see anger, that's probably the result of someone being in a lot of mental and emotional pain. To a large extent, my mental health problems, I believe, I really feel I know, were actually caused by, not all of them, but some of them, in fact, many of them, my mental health problems were caused by the way I was treated by the psychiatric field and law enforcement. My experiences have been traumatic. And because they have been traumatic, I learned to be fearful of law enforcement in the psychiatric field, which is really unfortunate, because, and when we see fear in someone, especially someone with mental health problems, we can often jump to the conclusion that this is irrational and assign to mental health issues, in my case, paranoia, right? But I had my freedom taken from psychiatric institutions, and, I don't want that to happen again. And I'm afraid of it happening again. One thing I'd like to talk about is stigma. The psychiatric and law enforcement fields often say And I know that there are different, individuals in the psychiatric fields and law enforcement fields are different. And I don't mean to generalize, but sometimes the actions of them are stigmatizing. Stigma literally means marked by illness, which is exactly what psychiatry and diagnosis is about. And it's not just diagnosis. The field says that we cannot be trusted with freedom, that we're dangerous, that our will is not our own. Is that not stigmatization? I believe it is. That we can and should be forced to take medications, drugs, that we're out of touch with reality. These are stigmatizing ideas. An important fact that I'm really glad to be able to share with everybody is that people with mental health problems are more likely to be victims of crime and violence. And the correlation can work both ways. In other words, when someone is victimized, it erodes their mental health. And when someone is mentally ill, they're more likely to be victimized. It's a very vicious cycle. And I'm hoping we can have this conversation and move in the right direction. One thing I saw that I wanted to address, that I saw a lot of in my experiences, was hubris. And people in the psychiatric field and law enforcement thinking that they know what's best when they're human, and humans are susceptible to not knowing what's best. And I'd like to wrap up on a positive note and just give two words that represent ideas that are really important to the issue of mental health crises. And those ideas are kindness and respect. And that's the cure for mental illness. It's not, neurological chemistry is part of it, but really the way to resolve these issues is through kindness and respect. Again, I thank you very much for this opportunity. I think this is an important conversation, and thanks for listening to me.
Jake, thank you very much for your testimony. And it was not only courageous of you, but has taught us so much. It was valuable, and my field of psychiatry obviously has much to learn still by listening to your humanity and your voice and that of others that have suffered from mental illness. So thank you so much for that. The next panelist is Dina Johnson, who is founder and CEO of Monroe County Family Coalition. Dina?
So thank you, Susan B. Anthony, for putting this wonderful webinar together today. I'm going to talk a little bit about the Monroe County Family Coalition, as well as personal experiences with emergency response in the community. So everybody knows about the aftermath. I get a little teary-eyed because with our culture today, it really is escalating, because not only George Floyd, there are several other many people that are dealing with either mental health, substance abuse, substance use, and it's not really being corrected. So I had the opportunity with my 14-year-old daughter, who's now 15, to talk, to have a conversation about what was going on, specifically with the George Floyd. And through that conversation, she talked about how uncomfortable, how sick it was, and pointed out that Black history was not even really taught just once a month out of the year, but in it being taught out of the year, it didn't really talk about, it only really pointed slavery to her more than civil rights and human rights. So having that conversation with a 14-year-old is like, wow, what do you do as a parent? So I actually asked her, what do you want to do? How can we go about this? I'm not an activist, neither was she, but I pulled in several activists that I knew in Monroe County, as well as friends, to say, my daughter had a conversation with me. She see what's going on in the world. She's inspired by a march. So she wants to be a part of this. So we did it. We did it in June 20th in Greece. I currently live in Greece. And we got a little bit of lashback from our town supervisor after I went through all the steps that you don't have to do ideally for a protest, or I didn't really like to call it a protest, I called it more of a march. That I went through the town supervisor, went through the police, had good rapport with everyone, worked with the school district, had everybody in the know what we were trying to do. And it was really to address diversity, inclusion, and equity with all the different important key stakeholders in our local law enforcement. So with that, after the march, I was really shocked because our former chief of Greece Police called me and said, Dina, I want to have a conversation with you. We had several lists of demands. I like to call them goals that they led to. But with those, with the list, we talked about the recruitment of policing. In Greece, we only have 3 officers that are Black and brown. So how could we change that dynamic? We talked about training. It was imperative that, yes, we have a crisis intervention team, but how do we go about training? How do we really work with the community? And how do we be more community focused? We also talked about what do I see or what can I help with? So I brought in another board that I sit in to talk about cultural responsive education, but also restorative practices. And so from that, I got another call from the school district. I got a call from the board. And so we had a roundtable discussion, which is what I want. We started with a march. I started off saying I'm not an activist, and I'm not. So, but I want to show that we needed change. So from that, we had several conversations for a roundtable discussion. Never in a million years would I think we would form a coalition from this. So it was 5 people that stayed on with me after the march and said, Dina, we need to figure out how we can do this, how we can get involved, and how we can empower throughout Monroe County, but starting with Greece as an example. So with those conversations, we wind up getting incorporated in September, and now we are 501c3. So to tell you a little bit about what our vision is really to create opportunities for family to bring about change, bridge inequality gaps in the community. And our mission is really focusing on local families to community resources, bridge the gaps between local governments and partner agencies with our youth, but really our at-risk youth and families. Families is very important. I think they get left behind a lot of times because we want to do a one-off and then we don't bring in the government bodies that can make the change. We also wanted to create safe space for a courageous dialogue between various entities within the community that addresses diverse contentious matters. As always, we want to be able to consistently explore innovative ways to advocate on behalf of families. Again, to me, it's very important that we get everyone in, and we have to start looking at bridging gaps. And we want to see ourselves as that consultant to connect people with government agencies, as well as different resources in the community. We want to be able to help the community and serve the community with integrity and consistently explore innovative ways to advocate on behalf of our youth and family. So we do have a board. Our board of directors consists of many people from many walks of life. We have a mental health counselor on our board. We have a cultural responsive education teacher, case managers, and we even have HR people to kind of help us lead this way. So it's all walks of life, and we're really working together to see what we can do. And our number one priority, we know public health with racism, with mental health is a big priority right now in our country. And addressing it in diversity and being inclusive as possible and ensuring that we are working with our government bodies and key stakeholders we feel is key. We hear our local law officials, we hear our politics, and we want to make sure we're getting on the forefront to see what can we do. We may not have the credentials for that, but what can we do to assist you to make sure our youth and families have a voice and being able to be heard. So our passion is, we're not there, we're a long way from here, but our passion is to be that one-stop shop that will allow residents, again, right now we're starting in Greece, so we're really small, but we want to expand, is to look at ways to have technology, tutoring, childcare, addition to mind and body wellness, exercise programs, most importantly, mental health support. A lot of people are wondering probably why I'm so teary-eyed about this, because mental health, I have a little bit of a personal statement. I know I don't have much time, but it'll help to understand why it's so passionate for me. So really being able to sit with the police department in Greece have been really extraordinary. I mean, it's been incredible experience that I've had, despite what is going on. I had the opportunity to work on our town advisory board for Governor Cuomo's 203 executive order, which was able to give our perspective of why it is so important to have community policing, why it is so important that we have key players, not just to put people into the community, put police from the community who live in the community if they don't know the community. And that's the same for when we build on more people, more clinicians we hire. How well do they know community? How well are we mobilizing the community? And how well do we know the people? And as Jake mentioned, the empathy and compassion that we have for people. So that's where we're trying to go. And if you want to learn more about Monroe County Family Coalition, please visit us at MCFC Info. So that's MCFCINFO.org. And so now from a personal perspective of mental health is that I was raised by my dad's parents. So it's usually you hear more of the mom side, but I have the dad perspective. They were pastor and wife, but my mom had a history of substance abuse as well as mental health. Her substance abuse was PCP, and she shot herself. Unfortunately, she's deceased now, but not from that. She got herself together, got recovered from that, went through some psych, went through drug rehab and all those different things. And most importantly, she found God. So through that, and then my dad has a history of alcohol abuse. So when you see these lens of especially family support, of trying to be supportive, of working with health systems and knowing that you can't be that direct link to helping your loved one sometimes make you in a fog and you're like, where do I go? And then when you see stories of someone who's in a mental health crisis or has been on drugs or whatever the point is, and the result is death because we use our local law enforcement and not necessarily the right people at that time. Or we have a young girl who gets pepper sprayed, or we have another incident where someone was sent to a place to help and then an incident happened and then it alluded to death. It really bothers you. Those trigger factors come out because you're like, what can you do? You've been in this situation. I was blessed to have my grandparents support me, and you know, we all get older and we go our ways, and then we have to find ourselves. And I found myself with trying to build more bridges with the community and seeing what I can do to help because I know these situations. And I just would ask that if we are looking to bring in people from the community, police officers who live in the community, make sure they know the community. That is my one takeaway from this. If we want to bring in more clinicians, that's fine. It's good to have clinicians, but make sure you're looking at your advocates, looking at peers, looking at people who do know the community, who can help you de-escalate a situation, who can help you with youth, who are the right people who prepare that. And if you want to bring them in, make sure they are actually having the training to walk the streets, to know it, not be scared, not have perception bias, but be a part of it. And again, Jake mentioned it so well about the empathy, the kindness, the respect. We have to have that. We have to have the collaborative effect, and we have to be kind and love one another. So my takeaway is community focus, and how can we bridge these gaps with inequalities with Black and Brown communities? Thank you.
Thank you, Dina. That was wonderful. What advocates. And your daughter, how admiring. for her to have come up with this idea and for you to have, channeled it for her. It's wonderful. I want to remind the attendees, if you have any questions, please put them in the chat box and we will answer them at the end of the session during our Q&A session. Next up is Sergeant Steve Boyley, Commander of the Crisis Intervention Team for the Rochester Police Department. Sergeant Boyley.
Hi, good afternoon. Thank you for having me here for this afternoon for this presentation. Hopefully I'll be pretty brief so we have some more time for questions later on. The last year has been pretty challenging for law enforcement, both locally and across the country. Some of the issues have been self-inflicted by members of law enforcement. Some, like COVID, are beyond our control. I'm glad to say that here in Rochester and in New York, in Monroe County, we're lucky enough to have a lot of law enforcement leaders who have embraced the need to change how we do business. And that goes back years, not just recently. In 2004, the Rochester Police Department was the first department in the state to implement a CIT program with the help of Dr. Kamen. I can answer more questions about that if anyone has them, so I don't take up too much time. But we did implement this team by partnering with members of the community, people from the hospitals, people from social service agencies, the courts, public defenders, district attorneys, and consumers to try and find a plan that would work to help us improve our services. Currently, the Rochester Police Department continues that collaboration with a lot of those community members. We meet regularly with the service providers, the hospitals, to find out what we're doing right, to find out what we're not doing so well, so that we can improve all the services that we provide and the treatment process as well, and not just specific to law enforcement. Some of the improvements that have been made over the years and more recently are changes to policy that govern how law enforcement interacts with the community. Most recently, we've implemented, and this is again specific to Rochester Police Department, a policy for a duty to intervene, meaning that members of law enforcement, if they see something inappropriate happening, are bound to stop a fellow member of law enforcement from that action. We now have a mandatory de-escalation policy so that our officers know that that's our first step whenever possible. And we've rewritten our policy on dealing with people that are having a mental health crisis as as was mentioned earlier, to destigmatize mental health issues. As you mentioned, I think in the beginning, it's not a crime and it should not be treated as such. And we don't want the people we interact to think that they're doing something wrong. It's an illness, not a crime. We've worked with the Office of Mental Health for years now in the development of the FIT program, and are lucky enough to see that expanding most recently. Currently, we're working with Dr. Lyman Torres as she implements the PIC program, which looks like it'll be a great asset for our community. And we're glad that we can help out in a small way and work with them. Most recently, RPD's in-service, which is a training for every member of our department, was concentrated on de-escalation skills and dealing with people in mental health crisis. And in about 2 weeks, we're going to be doing another department-wide training that our chief just mentioned at a press conference yesterday. And it's going to be named after one of our former deputy chiefs, Robert Craig. It's called the Institute for Ethical Leadership. It's going to be a 2-day training that all of our members will go through over a period of the next few weeks. That's going to cover topics like excited delirium, what it is and how to deal with it. A panel discussion on the future of policing, how to deal with the adolescent brain, since that's it operates differently than an adult brain, and a presentation by former Attorney General Eric Holder on law enforcement, among other topics. Well, a lot of what I'm mentioning is specific to the Rochester Police Department. Every agency in this community, whether it be Gates or Brighton or Webster or the Sheriff's Department, are doing similar things. The leadership of these departments knows that how we've done business in the past needs to change a little bit. We need to be more effective in how we're dealing specifically with people in crisis. It's not something law enforcement was really designed for. And while we, as Dr. Kamen mentioned, Rochester Police Department, we respond to somewhere over 300,000 calls a year. Based on statistics, we believe about 30,000 of those are related to mental health issues. We do a remarkable job most of the time, almost all of the time, but it's those few that don't go so well that we need to look at, we need to improve upon so we can have better outcomes for everybody, because that one that really goes poorly reflects badly on everybody, and we don't want that to happen to members of our community. So, while we have made many improvements, and our officers really do a great job day in and day out with how they interact with everybody, that doesn't mean we're perfect, and it does not mean there's no room for improvement. We have work to do. And the Rochester Police Department will continue to work with our partners, both new and old, to do a better job every day, and especially when it comes to serving those members of our community that are the most vulnerable. I look forward to continuing my work, which concentrates on the mental health programs of the department and with our partners to improve how we deal with these people, because they deserve that, as does the community. And that's it. I want to be quick. So thank you very much for your time.
Thank you, Sergeant, for those encouraging words of change in the police department that I'm sure everybody is not quite aware of what's happening inside the police department. So I think it's important to bring that up.
Thank you, Doctor.
Next up is Dr. April Aycock, who is Director of Monroe County Office of Mental Health. And she hopefully is going to enlighten us about the Monroe County initiatives taking place.
Hello, thank you so much for having me. Thank you everyone for coming, and as well as Susan B. Anthony. I just want to say thank you, Jake, for your story. It was very powerful, your lived experience. It is very important for us to hear more stories like that, as well as hear what the recommendation is. And Dana, I want to say also thank you for what you're doing, as well as is very important. And I think you and I both, we have that lived experience of having parents and loved ones who are unfortunately involved with mental health and substance use. Unfortunately, during that time, our loved ones were criminalized with the drug on war, unfortunately. And I'll talk about that a little bit later. But I want to encourage people to continue to talk out. The great Maya Angelou said that there's no greater agony than bearing an untold story. So please, when you have an opportunity, please share your story, as long as it's in a safe, way. What I will tell you, as far as for the Office of Mental Health, the role really at the core of the Office of Mental Health, there's many things, but we really are challenge solvers, advocates, and partners. Our goal overall is to improve the health and quality of life for our community members affected by mental health, developmental disability, and intellectual disabilities, and alcohol and drug addictions. To meet the need, and there is definitely a need, we do multiple things. In particular, I'll point out just 3 things for this forum. Among many things that we do, we collaborate, we advocate, and we oversee and allocate state dollars to be able to help out in the behavioral health field for the whole greater Rochester community. When I talk about collaborate, what we do and what this means is we partner with local agencies to deliver critical services, especially in the area of pre-crisis, during crisis, as well as post-crisis. I'll give you an example. We are partnered with United Way as well as CPEP, and we have a new program, which is the Youth Behavioral Health Pilot. And this is dealing with youth who are in CPEP, and they actually connect with us. We help them to navigate this complicated behavioral health system. Any barriers that they are dealing with, we help to get them services. That has been very successful. It started in April, and we already have 16 referrals. And again, it started April, I believe 6th or 8th. Very successful, and that helps out with post-crisis as well. We also have a homeless partnership grant that we are doing, collaborating with Person-Centered Housing Option, Liberty, CCSI, as well as MC Collaborative. And what does this do? This helps out with our homeless population and help them to get housing, as well as providing them with services to hopefully prevent, law enforcement engagement, as well as prevent any unnecessary hospitalization. Again, that pre-crisis as well as post-crisis. We also have, as Dr. Kamen said earlier, we have our forensic intervention team, which is during crisis as well as, post-crisis as well. We co-respond with law enforcement officers to deal with brief crisis solution focus, referrals, as well as follow-ups for the whole Monroe County as a whole. The other thing that we do, and it's the last one in this collaborative area, is we have partnered with Rochester Regional with the diversion programs. So individuals who are incarcerated or going to be released, providing them with services, connecting them with services, and any barriers that may be at hand, we help them through that process. Again, we partner and we collaborate with agencies. The second thing that we do, among many things, is we educate and we continue to speak up at a state level. Now, I have to be very transparent and honest. Most of these state meetings, I am probably one out of maybe 3 or 4 Black people that are in these rooms having these conversations. We had a budget that was passed April 1st, which happens to be, my birthday. And one of the things that the state is really pushing is crisis stabilization services. So we're having dialogues as to what would that look like for our community, providing, suggestions with that as a whole, and really having those conversations of the underrepresented population. How are services being provided for them? How are crisis services being provided for people who have intellectual disabilities as well? One example of something being successful, talking with the state, is the Villa of Hope has a Hope Place, which is a living room model for psychiatric crisis. Very successful program as well, but that also helps out. And Dr. Kamen also mentioned earlier the federal legislation mandate of a 988. I actually am on that panel to be able to see what, how is this going to look in the future? It will happen. And the plan is that it will happen by July of 2022. The third thing that we do, among, of course, like I said earlier, many things, is we oversee and we allocate state dollars. So we really are the stewards of critical state aid dollars when it comes to programs that are especially non-billable services. So we talk about non-billable services, that means that insurance does not cover those services. And so, for example, some of that would be like a skill building for, especially for our youth population, peer services. Of course, we're hoping that things change with that, especially with the pandemic and peer services, respite as well. And so I think people are very familiar with Infinity Place. So those are the 3, main areas. We also do other things, but I have to say personally, being in this role, I'm very honored, but I have to say I am committed to equity that is being met throughout the whole behavioral health system, not just the crisis area, but the whole behavioral health system, looking at services and how it's being delivered, looking at barriers to the underrepresented population, as well as our rural area population as well. Our data shows that our Black and Hispanic population is not getting the services the way they really should be getting those services. So I am committed to doing that. We are at a point, I think, just as a whole, we're at a point where all areas, when I mean all areas, for example, I mean education, policing, as well as behavioral health, among many areas. we're at a point where we can really look at this and look at our policies, our practices, our structures, and really looking at where the barriers are, which is very, very important, because behavioral health services should be accessible to everyone, including Black, Indigenous people of color. My office is committed to having those conversations, and we are having those conversations with providers. Going forward, what is some of the things that we need to do that needs to change? There are many things, but I'm just going to point out 2 areas for the purpose of this forum. We need to reimagine what mental health and substance use looks like. We need to really look at that through a different lens, okay? Because the way mental health and substance use looked 5 years ago, 10 years ago is different than the way it looks now, and we have to start changing. Our behavioral health services is pretty much like a 9-to-5 job. Mental health, substance use does not stop after 5 o'clock or on the weekends. We have to look at it differently. Also, mental health, we're talking about it more. It is much more accepted than it was before. Why? Because of the global pandemic, and certain populations are now being affected by that. Another example, when we talk about substance use, and I mentioned this earlier, in the 70s and 80s, and even in the 90s, it was the drug on war, which you had mass incarceration. Now, when it comes to substance use, you have the opiate epidemic, or the opiate crisis. We need to make sure when we look at the opiate epidemic and crisis, we're also looking at that for the Black, Indigenous people of color, and not criminalizing them because of that. So we need to start looking at that. The second area we need to really focus on as well is integrated services. You cannot just treat a person one area. You have to treat the whole person. We are an intersectionality human race. We have to make sure that we're treating the whole person as well in a culturally responsive way. And I'm going to say that with emphasis, in a culturally responsive manner. We have to start changing and focusing and shifting towards that. And I have to say, if we don't start looking at this, we're going to continue to perpetuate this issue that we're in right now. It is not going to change, because history will continue to repeat itself. And instead of us dealing with pre-crisis, we're going to continue to remain in this place of crisis. So at the end of the day, I challenge everyone to look at their area and say, what do we need to do to change? How do we come against and we move away from the status quo that has gotten us where we're here today? Thank you so much. I know my time is finished.
Thank you, Dr. Aycock, and I want to say thank you for that. I'm sure people are going to want to know about all the programs you elucidated. So if you could at some point put in the chat box, I'm sure your webpage has all these great programs, some of which I actually didn't know existed. So I'm glad. Last but not least is Dr. Danielle Lyman Torres. She's City Commissioner and Director of the Person in Crisis Team, or PIC team.
Thank you so much. And I definitely want to thank my partners in this work, many of whom are on this call, Dr. Aycock, Dr. Kamen, Sergeant Boyle. We work together every day, and I really want to thank Jake and Dina for their stories, because this is so important to the work that we're doing. As you've heard, there are a number of reasons to consider alternatives to both police and the hospital as the only responses for mental health. The City of Rochester commissioned the Person in Crisis team as a pilot program to work on introducing a law enforcement alternative to the public safety system in our region. It's important to note that in cities across the country, they're piloting similar initiatives, and all of them began working hard on this following the outcry for police reform. Rochester, no doubt, has had our own catalytic event pushing us into action. Like other cities, we looked for models and learned a substantial amount about what others are doing in the country. The Cahoots program from Eugene, Oregon has been in place as an alternative response team for 30 years. We looked to them for inspiration, but recognized Rochester has its own and unique needs. The potential work for the PIC team does go beyond mental health. It is important to note that alternative response teams also respond to wellness checks, family trouble, and even eviction support as behavioral health, as well as the behavioral health calls. However, we did in fact launch the PIC team, beginning first with the mental health calls. Our team of behavioral health professionals, they work 24/7 as a resource, first to be focused on the calls coming in that the team could do alone. Those are the types of calls that do not include weapons or medical emergencies. We advanced to being dispatched as a co-response with RPD in mid-March. We're 3 months into the pilot. A lot of people think it's been longer than that, but I can tell you it's just been 3 months. But what we are seeing is that we're averaging 100 calls per week. The idea is not about simply just partnering or being a co-response. The idea is about evaluating the right resource for the response. And we can only do that with a pilot where we go out and we evaluate situations which may have previously been determined to be appropriate for police response. So we need to make sure that as we're doing our pilot, we're launching things incrementally to maintain the safety of not just the responders, because trust me, our professionals understand the risks that they take in the work that they do, but also for the people who are in crisis. We want to make sure that as we evaluate the right resource, that we're doing so thoughtfully. So we are doing that evaluation as we co-respond. Are these situations where the police or EMS or both were not really necessary? And we're going to be able to have that information which we can evaluate hopefully together as a community when we have the results of the pilot. I can say that, you know, we are growing the team. We initially started with 14 members. We're growing to 30 members because we do want to continue to enhance the work that we're doing. We want to enhance the work with the integration of peers. We want our next steps to enhance the work we're doing on follow-up and ongoing supports and expand to those additional types of calls I talked about that alternative response teams are doing across the country. As I said, we will continue to evaluate and work with our community partners to best meet the community's needs. I can tell you that what we're seeing is that people need support in between visits to clinicians. Community-based supports to help people with daily living, treatment adherence, and a number of other activities that are challenging as people navigate the symptoms and manifestations of their illnesses. As a community, we have learned to better support populations with other health issues. We need to capitalize on what we've learned and treat people in crisis as people first. I want to thank the members of the PIC team who are working hard 24/7 to serve their community and partner with others as we embark on this pioneering effort. But this is just the beginning. This is just the beginning of the transformation. And this is not the final answer. One of the reasons we explore and evaluate is so that we can identify and keep working toward that. But we were never going to do anything if we didn't take the first step. So that's what this is, the first step on a way to reform. But we want to work with our partners in the community to develop that together. Thank you.
Thank you very much, Dr. Lyman Torres. Thank you. I think with that ends our presentations. Anybody that would like to have a question answered by somebody in the panel, one of the panelists, please put your questions in the box. There are a couple questions I saw over here. I gotta serve here. Well, I'll start at the bottom since it was easier for me. This is for Dr. Lyman Torres. When co-responding, is there a high percentage, would you say, PIC team is not given permission to access the scene by police? If so, what adjustments can be made to the protocols to increase the percentage of services provided?
I would not say that there's a high percentage where PIC is not given access to the scene. What I would say is that we need to continue to work on all of our protocols, not just with RPD, but also with EMS. Because what we are finding is very often people are being transported, to the hospital before we can really go through a real full assessment. And so I do think that we need to take a look at that part of it. But we have not experienced, being, having a lack of access to the scene. We're encouraged and supported to be there, but we do still have some areas where, we are very fast in getting people transported, but we need to take a look at if that's always the right answer.
Dr. Torres, there's a couple more questions related to the PIC team. Is the PIC team connected with health homes or SPOA to make referrals for ongoing care management? Our agency provides this support to connect members with ongoing services to help avoid crises. Is that something the PIC team is able to do? And also, just so you can answer it all together, because I think it's kind of related, is at this point right now, does the PIC team go out if a family member or other concerned person calls on behalf of the individual, or only if the individual calls themselves?
So I'll answer them in reverse order, because that's how I'll remember to do it best. So the PIC team can be accessed by concerned family members. We do encourage that access to come through 211. So we do mark it, as Dr. Kamen said, 211 as the number where we do want people to call. And we know that many people will still call 911, and that's why we are set up to be dispatched that way as well. But 211 is where we want people to call if they want to support people with getting access to the PIC team and it's not themselves calling. And then the answer to your second question, we're continuing to build the care network and working closely with our partners at the county Department of Health and Human Services. We encourage any agencies that want the PIC team to refer people to them or to connect people to them to reach out, and I will put our email and web address in the chat.
Thank you. There's one comment from one attendee that just says that with all due respect, partnering with police isn't it. There is a couple of comments. There's one for, okay, here we go. This one is for Sergeant Boyle. Excited delirium is not recognized by many medical associations, has come under fire as being used as a way to avoid police accountability in instances of in-custody death. Are you able to speak on what the training would stipulate for recognizing, treating this when its existence seems to be in question?
I can give you what we teach in the CIT school and in the Basic Recruit Academy. The science is uneven on it. I think the majority of medical professionals believe in excited delirium, but there are some that don't. But what we teach in CIT school is to look for 3 different indicators. Behavioral, that's people that suffer from excited delirium have an affinity for shiny objects. They're attracted to windows, bright lights, things like that. In Rochester, we had an example where they were at a grocery store and with the big windows, lots of lights in the parking lot, things like that. The taking of clothes off because the core body temperature is getting so hot. There's verbal cues like grunting, intelligible or unintelligible vocalizations, things like that. And then some psychological indicators like paranoia, intense fear, things of that nature. That's the brief version, but there's that kind of stuff that we talk about in a block of training in the CIT school specific to excited delirium. The recruit class, it's much briefer. It's 1 or 2 PowerPoint slides that kind of encapsulates the basics of that. I think that will probably be changing in the near future, but that's a state program that we don't really have a lot of control over.
And that you said that was a 2-day training for that, or 2 slides for that, right?
The recruit training, there's only a couple slides covering excited delirium over a 2.5, 3-day training. CIT training is a full week, a 40-hour training.
Let's see. If I'm scrolling through. Can you see any there?
Yeah,
John?
there are 2 earlier. And so here we go. And I don't know if Dawn or Sergeant Boyle may be the appropriate respondents for this, but if anyone else feels that they can, please do. Police mental health street triage is an increasingly common intervention when dealing with police incidents in which there is a suspected mental health component. Still, too many people are dying at the hands of police. Why is that?
From a police perspective, there's just too many interactions. But when you say too many, I think 1 is too many. But again, if you look at, and I'll only speak to RPD, of over 30,000 interactions a day, or a year, we do a pretty good job generally. It's that 1 that really goes poorly that makes the news, as it should. And that's the one that will drive change. And unfortunately, it's usually a tragedy that causes that. But again, as has been mentioned by several people, law enforcement was never meant to be the response for a mental health crisis. We do a good job, but we're not a clinician. We're not like some of the FIT staff, the PIC staff. And unfortunately, some instances, bad things happen that are, sometimes it's our fault, sometimes it's out of our control. And it's a tragedy either way.
Oh, yeah, I mean, I would just echo Sergeant Boyley's, remarks, and I would say that was sort of what I talked about, which really is it's a system issue. We don't, even though you're right, Sergeant, your folks do, and other law enforcement, the majority of times the outcomes are just fine. We want to minimize the times that law enforcement are those first responders to get those numbers even lower. I will say that there's, training issues, which you alluded to as well. The, typical sort of what's called the command and control approach that law enforcement are taught, which is really helpful for the majority of types of interactions that law enforcement have, oftentimes are not helpful when somebody's in an acute mental health or emotional crisis. And that's really the CIT training really looks at and tries to help folks understand. So first, number 1 is to recognize that there are, mental health crises, and that may require, or often does require, a different type of response. And one last thing I'll mention is that sometimes individuals who are in the midst of an emotional crisis, just by police showing up, even before they have a chance to say or do anything, their mere presence can be more upsetting and raise that anxiety, raise that distress level. And so therefore, just by showing up, sometimes, people have a negative reaction. No offense, Sergeant, but they do. And again, this all, at least from my perspective, this all comes back to why we need to continue to look at our systems the best we can, and to support the expansion and development of things like PIC and FIT and all of the non-police responses that we can possibly have.
I just want to add something to that, to those points. And this goes across to all systems, and I'm gonna be very specific, all systems, okay? We need to talk about implicit bias and cultural responsiveness, because that is huge when we talk about every system with the response, with responding, because you see individuals who are white and getting services and responding to services do not end in death. So we have to talk about that as a whole. And I've said before how even the American Psychiatric Association issued an apology for the damage that they did, in the testing and, you know, the experimenting and harm that they did on Black individuals. So again, when we have these conversations in these forums, we have to go a little bit deeper and talk about how are every aspect of crisis services, how are every aspect of policing, how is every aspect of education, every aspect of housing, every aspect of poverty, how does it deal with implicit bias and cultural responsiveness? If we don't start doing that, then again, we are going to continue to perpetuate the issue that we have today. I'm very passionate in that. Hopefully you hear it in my voice, because again, I don't want to be here 5 years from now, and I don't want my grandkids and my great grandkids having to deal with the issues we have going on right now. We have an opportunity to do something different. And what did Maya Angelou say? When you know better, you do better. And so that is important for all of us to do better.
I was just.
If I could just add one thing, Dr. Aycock, I totally agree. And I would just say that it's not always implicit. Sometimes I think the biases that we have are absolutely explicit. So I want to put that on the table. As a white guy, I want to say that.
Thank you for highlighting that.
That was something I was kind of going to say, alluding to what you said, Dr. Kamen. I know I brought this back to our Greece police, is the mental health of officers, knowing that not only do they might bring in their perception biases, but also how do they come to work? Are they getting adequate training for that? Are they prepared when you have these situations that you don't just always react? And I think sometimes the mindset can be a little off, and not speaking negative towards the police, but what I'm saying is we have to get them help, because I brought an article to their attention that this gentleman who was a police officer, served in the service, Black, wind up taking his life. I shared this with the mental health work group of the Race Commission because it really disturbed me. So it showed to me that, you know, how well are you helping out with their mental capacity. So when they do come to work, if they say, oh, you know, I'm having a bad day, I've had issues at home or whatever, we all may have these challenges with mental health. Can I just step back, and this might not be the right call? What services are they getting to that may help mitigate some of these interactions, and specifically in the Black and Brown community?
I'm glad you mentioned that, Diane, and I'll just throw this out as well. We don't talk a lot about vicarious trauma either. And we don't talk about that with the police officers either. So that's also a topic that should also be talked about too.
Point well taken. I think that the trauma goes both ways. I think police are as traumatized by some of these events as the public is listening to them. And we have to also take that into consideration. With that said, Officer Boyle, I have another question for you. I'm going to read it because I think we need to talk about this. And I'll leave it up to you whether you can answer it or not. Thank you for your presence here today. What are your thoughts about the mandatory de-escalation policy as it pertains to the Daniel Prude case? What was done to discuss within the police department the issue of duty to intervene with officers that stood by as Mr. Prude was physically restrained on a cold winter night without the kindness and humanity that Mr. Hutto so brilliantly spoke about today?
You're on mute. Okay.
Yeah, I figured it out. Took me a minute. I have to be careful what I say because I was a witness in the grand jury, and I expect with civil litigation, I could be a witness again. The de-escalation policy did not exist a year ago. That's a recent development, so it had no bearing on that incident. I can say that the members that were there are still facing disciplinary action. I can't offer an opinion as to that because, again, it's ongoing. I can say I might have behaved differently, but I don't think the outcome would have changed based on if, for example, they gave him a blanket due to the weather and the temperature. I think medically that would not have made much of a difference. But either way, it's a tragedy for everybody involved, and that shouldn't happen to anybody. He deserved better from the hospital, and from everybody involved.
Okay, thank you very much for answering that question. What, if anything, is being done to encourage police officers to build relationships with those in the community they represent?
So RPD for years has followed a philosophy of community policing, trying to get officers out of the cars and to walk around neighborhoods, things like that nature. That's why we have our Community Affairs Bureau and our crime prevention officers. The reality is our call volume is so high and the number of officers low that most nights our officers are running from radio call to radio call. They don't have the chance to be as effective as they want to be and as we should be of walking down Dewey Avenue or Emerson or Hudson Avenue. There are times when they're assigned to do it, but there's nowhere near enough of it. We do have other programs like the PAL program to get officers into schools, playing games with kids, reading to kids, running softball games, things like that. But the reality is there's not enough officers to do everything we want to do. And I don't know there ever will be based on budgets and things like that. Those are decisions that are made way above me.
Are more officers getting CIT trained in the local community than last year, let's say?
So historically, we've run one school a year, which trains about 30 officers countywide. I can say that for RPD, we have roughly 120 officers out of 650 officers that we currently have that have been trained. Earlier this year, the chiefs of police of all the agencies issued a statement that they want every officer that's on the road to be trained in CIT. So this year we currently have 4 schools scheduled. That'll be roughly 120 officers among the various agencies. And the plan is that every year we will have 4 or 5 schools to train. It'll be a few years, but the goal is to have every officer with this training.
Thank you.
So, yeah, Talba, sorry. I just wanted to make sure this question wasn't overlooked, and it was earlier, and it's from Dr. Nestro, and again, whomever feels that they can take this, please do. When we evaluate things that went well in community crisis interventions, are we also getting feedback from the consumers who were recipients of the response as part of this evaluation?
Well, I'm not sure if this answers that part, but for the CIT training, probably the best part of the training, and I think the part that is most impactful, is on usually it's the last day. We have people from NAMI, the National Alliance for the Mentally Ill, come in. Some are family members, some are consumers, and they talk about their experiences with law enforcement, and sometimes it's not positive. And those are the ones I think that really have a impact on the officers in the training when they hear that they weren't, the cowboy with the white hat, that, the person they're going to help was actually scared of them, and it helps adjust their perspective and hopefully their reaction when they respond to those calls. That's how we change our programming in terms of PIC. And the other programs, I'll leave that up to the people that understand statistics and all those kind of things.
But I'll just add that I think Dr. Nestro makes a real good point. I think it's a relative weakness when it comes to evaluating, crisis response services. We, and that's just not Rochester. I think that's nationally. When you look at the literature, you look at the policing and CIT literature that shows some good outcomes, but very rarely is the evaluation structured in a way to get the input from the people that matter the most. And some of that's for obvious reasons, that folks that are in distress, it's very difficult in the moment to get, an appropriate kind of feedback. But after I think we need to do better. If that's part of the question is, yes, clearly we need to do better and think about ways to get that information. and not just sort of pat ourselves on the back when we think we've done a good job, because sometimes that's accurate. Sometimes it may not be as accurate as we may think.
I do feel like I need to, there's a lot of questions or comments about excited delirium that I kind of just want to clarify for the sake of all those others attendees. I think Sergeant Boyley answered the question according to his training and his understanding. However, there's a lot of comments in the chat box about it not existing in major medical associations such as the AMA and the APA, also noting that it is problematic to say that the majority of researchers or clinicians support the notion of excited delirium. It has no diagnostic standing without a unique treatment or prognosis. Delirium exists, but excited delirium is what's being questioned as an entity. Thank you. I think that is about all the questions. If anybody has it.
Can I just highlight something as well? Because I know that we talked about PIC and we talked about FIT, but I think it's worth also saying that we also have 2 other crisis programs that are doing excellent for our community, and that is VHAC, as well as our mobile crisis that's through the University of Rochester. And so they are doing well. And we have 4 crisis programs and they meet bi-weekly. They work very well with each other to help out with the, what's going on in our community as a whole. So we're proud of all of the crisis services that we have here.
There was one question about URMC. I guess I'm the URMC representative, but is a behemoth of a place and I don't know all the details. I know that I sat in flips when we were talking about the crisis center at St. Mary's. There was an interest at that time not to replicate services, but to have different services. So URMC was not going to have a crisis center like that per se, a type of walk-in, so that there could be other services. That being said, we are in discussions about having crisis call line and crisis counselors at our Chestnut Street location. But that has not quite materialized right now, but it's happening in the future. And hopefully that's a center city location where people might be more likely to go and find it easier to access care.
Thank you, Dr. Oliveris. And with that, I just want to be mindful of time. And again, this was, a rich, informative discussion, and we hope it continues beyond this webinar. And we know there have been discussions in the community, but we hope we've provided you with more information about services and efforts being made right across our community through different organizations with our policing. And I really want to extend a heartfelt thank you to all of our panelists for attending. I mean, this was a new one for us to have 6 panelists, and we were really excited that we would have that content. And in addition, Dr. Oliveris, thank you very much for facilitating and moderating the panel. We really appreciate your insight and expertise. I also would like to wrap up by thanking Catherine Farrow from the Susan B. Anthony Center, who's also on the call, who really helped facilitate and put this together as far as the logistics go. For those of you who are interested, we are recording this panel. It will be available on the Susan B. Anthony Center YouTube channel in a few weeks after we send it off for closed captioning. Please feel free to follow us on social media. We have a Facebook page and a Twitter feed, and we will be continuing these panels around community inequities. And also on our YouTube channel, you can see our previous ones on topics that range from child poverty, Rochester, a city in crisis, to housing injustice. So with that, thank you very much for your interest in attending this panel, and we wish you all a pleasant evening. Thank you very much.
Thank you. Have a good night.
Thank you.